But again, like, so even, in the 5 minutes I was there, I hadn't gotten all the way to that patient. Thankfully, we have lots of both non-medic first responders, which again are super important in these mass cal situations, and medics that had, launched at the site of an incident and ran to the scene.
No, I think that I think that one of the things you look at is triage is basically sorting and prioritizing your treatments and your evacuation, kind of at the same time. And it's not a one and done. It is a continuous thing that even when you get to the last patient, if you have that time, you're going to start over again, and you're going until you get everybody out, everybody to other care, to more resources, that they need. And I know in our older doctrine, triage was done by the most senior medical person on the ground at the site.
Yeah. So, that's a good point. That's a good transition into, I guess, so when I look at the triage, we talked about like first contact, undifferentiated patient triage. That's the first pass, right? And then once that is over, once life-saving interventions have been applied, once you've moved to a CCP, then you can do that more deliberate touch and start to delineate more into these urgent priority routine. That's what I use, whether or not people use DIME or P1, P2, P3, or the USA, the unstable, stable, ambulatory. And that's really the people with unstable vital signs. So that's super rapid pulse, a thready weak pulse, really high respiratory rates, they're really tachypnic, or their mental status. That's honestly one of the biggest ones for me, is when someone's mental status starts to decline. That's one of the last signs that they're coming unstable before they start really entering that unsalvageable territory when they go too deep into a loss of organ perfusion. If it's a peppering from a remote blast versus a gunshot wound, that's kind of where that mechanism of injury in my clinical gestalt may shift them into urgent, even with stable vital signs. But then again, head injuries that have any sort of altered mental status, even if it was temporary, and like I said, that or significant fractures. And I mean here, like kind of higher fractures, so not necessarily ankle, wrist fractures, but I'm talking like femur, pelvis, suspected neck or spine, bad clavicle fractures. And then not ambulatory patients usually are going to go into this category. Eye injuries is one that I left out. And then routine is your walking wounded. And the important thing here is that the routine, these walking wounded patients, your routine or your third category, your minimal patients, they may not present right away. In the military setting, these people will often be the ones providing security, or they're going to be your non-medic first responders.